Fleet architects were asked to prepare a short presentation speculating on how the COVID-19 pandemic might change the design of primary care buildings. Some of the proposals are short-term, whilst others are longer-term and will complement new ways of working. A vaccine will not render the ideas redundant. Many are already good practice regardless of the pandemic. Building in future functionality will help a response to a future pandemic, while maintaining the best aspect of the general practice model, continuity of care and mutual trust. Lobbies could help to control and manage access. Antimicrobial matting could be installed. Door activation could be triggered by the use of contactless sanitizer dispensers. Access, when granted, could bypass a reception if the visitor has logged in remotely. Maintaining good visual and audio connections to limit confusion will still be key. In times of pandemic, as being explored at airports, heat-detecting cameras could be used, with access being granted or the visitor being directed to another site or a dedicated hot zone. The current design of receptions do not allow for social distancing. Use of glazed screens could be considered, however, there is a risk this could impair communication. Perhaps deeper desks would allow for social distancing whilst maintaining good communication. Waiting areas present a challenge. At present, at 1.5 square metres per seat, a 12-seat waiting area requires 18 square metres net. At current German social distancing levels, 1.5 metres, this area becomes 27 square metres in total. At UK standards, it increases to 48 square metres. So, unless much larger areas are allowed for, the numbers present will need to be managed if any social distancing is to be maintained, either by using remote consultation or technology to govern more precisely when people need to attend. A slight slip in a session schedule can easily cause overcrowding. Use of a smartphone app could alert people and prevent early arrival and longer waiting times. Circulation generally and crossflows create contact points and greater transmission risks. Could flexible zoning be used to segregate risk profiles, including those at specific risk, or a dedicated hot zone? Learning from supermarkets, could one-way systems reduce crossflows, including dedicated exits, but also reducing contact point risks with automatic doors and antimicrobial finishes, such as copper or silver alloys? A temporary hot zone should be served by staff changing areas for the donning of PPE. And car parking will always be limited in London. All new health centres should always provide adequate showering, changing and locker space to encourage good infection control. Of course, we need to maximise the opportunity for effective cleaning, and excellent ventilation is essential. How might the 16 square metre consult and examination room change? With increased use of phone and video consultation, building on the popularity of services like GP at hand, how much of the equipment, and therefore the space to house it, becomes redundant? With dedicated video consultation, could spaces a quarter of the size be used? Set up with cameras, high-resolution screens, lighting, acoustically balanced and insulated, the quality of the interaction will be maximised. At present, the examination couch is used in less than 1 in 20 appointments, but could increased use of virtual consultations mean the couch is actually used more often when attending in person? Could equipping the room for more virtual interaction and teaching even justify enlarging the typical room? It's likely a mix of different styles of virtual consulting and physical consulting and examination will be required in the future. In offices, could furniture be designed and specified to allow for safe social distancing when required? Dedicated keyboards or laptops connecting to desk-based screens. Wash and wipeable furniture or disposable placemats, as some furniture suppliers are suggesting. More calls and remote working means more use of headsets is also likely. Office spaces will need to flex, allowing for greater numbers when social distancing is not required. Will there be return to cellular offices? We don't think so. Numbers attending the office are likely to reduce, either with more remote working generally or use of A and B grouped days. Fleet are currently replanning an existing client's office to accommodate fewer but socially distanced workers. Standing desks and touchdown between clinical sessions will still be useful. Virtual meeting rooms can also accommodate quiet private work or even small group meetings. Again, we could employ sanitizer dispensers to release doors and maintain hygiene. Phone or video booths are also increasingly common in offices and could help multi-professional teams to interact. Shared kitchens present a risk. Would staff discounted cafes and refectories be safer? Looking at the system-wide picture, moving more enhanced services into a community setting will help to protect the most vulnerable attending hospitals for more complex treatments. I hope some of these ideas are useful for your primary care or other settings. Please get in touch if you'd like to discuss your organisation's specific considerations or needs.